Good morning, everyone, and good morning from New York. We have Dr. Beasley here from Mount Sinai. As we all know, those who do not know her, so she is an attending pulmonary pathologist at Mount Sinai, and she is very well known in the field of pulmonary pathology. So we are lucky to have her with us. So she has a few cases, mostly related to pleural pathology, and she will go over the cases now. So thank you, Dr. Beasley, for your time with us today.
Okay, thank you. All right, so today we're focusing on pleural pathology. So I brought 12 cases. I'm not sure if we'll get through all of those, but hopefully you will learn some beneficial information as well as some pitfalls to avoid. So we'll start off with a kind of basic one. So the history I provided for all of these cases was pretty much the same. So this is a 65-year-old with diffuse pleural thickening. So one thing, while all the histories for these cases were the same, so you might think that's not really helpful. What is important when you get a pleural biopsy, just before we get started, is this is not the place to be lazy about looking up the clinical history or the radiology. So when you get a pleural biopsy, you really want to know what the radiology shows. Does the patient have multiple pleural nodules / diffuse pleural thickening, or does the patient have an intraparenchymal lung mass? So if you have multiple pleural nodules or diffuse pleural thickening, you know that mesothelioma needs to be in your differential. Now, certainly there's many things that can mimic mesothelioma and that distribution that we'll discuss, but if you have a localized pleural mass, mesothelioma only presents that way extraordinarily rarely. So other things need to be considered. And then additionally, if you have a mass in the lung parenchyma itself, that is not going to be a mesothelioma most likely, so that moves down on your differential quite a bit. So you really want to know what the radiology shows. And you also want to know any pertinent clinical history, because that's important for tailoring your immunostains. So do we want to go around and discuss these, or you want me to just talk about these, or how did you guys, we can go either way.
First, we went over this.
Okay, so who wants to talk about this one? Is there an arrow? Okay, so.
Okay, so go ahead. So the first, the top lining of, it's plural, right? So it looks like the mesothelioma, on the top. And then there's, the scattered of these focus. Of kind of, how do you say, I think the tumor cells, and there's some gland formation, and also with the papillary structures.
Right. Okay, so we have a pleura. This one's not oriented super well, but you can kind of see we've got is the arrow working? The chest wall adipose tissue on one side, and then the pleural tissue above it. And normally you should have only one layer of mesothelial cells and a thin layer of connective tissue. So this is way too thick, and we have cells infiltrating the full thickness of the pleura. Now the cells are kind of deceptively bland, so this is kind of a classic morphology, as is this papillary and tubular appearance. So you have kind of cuboidal cells infiltrating and forming these papillary structures. You don't really see much in the way of mitoses in this particular case, so it's sort of deceptively bland. And then here we have some that are forming the kind of reticular lacy type pattern and so forth. So what are you thinking here? What's your differential? We've got a 65-year-old guy with diffuse pleural thickening.
So mesothelioma.
Right. So mesothelioma, and what else?
It can be metastatic from the lung.
Right. So what kind of tumor from the lung?
the lung adenocarcinoma.
Right, so an adenocarcinoma. So essentially your differential here is going to be mesothelioma versus adenocarcinoma, either from the lung or someplace else with this kind of morphology. And this bit here, this guy's undergone a pleurodesis, so this is just some talc with some foreign body reactions, so sometimes you'll see that in these resected cases as well. So how do you want to work up mesothelioma versus adenocarcinoma? It's a popular question.
The 4 panels, WT1 coloration for mesothelioma, and then the EP4 and what is that? For no, that's for one or others. So first we're differentiating mesothelioma and adenocarcinoma, right?
Right, yeah.
The EP4 and one more for adeno.
Right, so
CEA we can do, right?
you can do. So basically you want to do a panel, and you want to do a pretty big panel, and you want to tailor your panel to what's going to be in your differential. So most of the time it's going to be mesothelioma versus lung adenocarcinoma, but there's some pitfalls to keep in mind if you are considering other types of metastatic tumors. And this is not the place to be cheap. So the US and Canadian mesothelioma panel generally recommends that you do a minimum of 2 quote unquote mesothelioma markers, if you will, and 2 adenocarcinoma markers. I also usually get a keratin in a case like this where you have well-developed papillary structures, making sure you're entertaining the right differential between mesothelioma and adenocarcinoma isn't as critical, but you'll see in some of the other cases where it has a different type of growth pattern, it is important to make sure you're entertaining the right differential diagnosis. And the keratin can also highlight infiltrative areas you might not appreciate on the H&E if you're having trouble even deciding if something's benign or malignant. So getting a keratin is a good first step. Now, I usually get a pretty big panel. The bigger the panel you get, it increases your sensitivity and specificity. So your mesothelial markers, quote unquote, are calretinin, WT1, like you mentioned. You can also do CK5-6 and D240. So those are the ones that we have on our side for markers. Other things like thrombomodulin, membranous staining with HB, ME1, you can see that. So those are your mesothelial markers, if you will. And then on your carcinoma side, you want to get some general markers, like you said, BER, EP4, CEA, those are good. B72.3 is also another one. LUM1 or CD15 is good. That one tends to stain a lot of background inflammatory cells, so it can be a little messy. And then TTF1 can be useful since most of the time you're going to be considering lung adenocarcinoma. Some important pitfalls to consider are if you're concerned about metastatic breast carcinoma, a lot of people have been using GATA3 as a breast marker. So GATA3 can stain a fairly significant percentage of mesotheliomas, so you want to be careful about that. And then conversely, breast carcinomas, particularly if they have a basaloid morphology or they're triple negative, can also stain a significant percentage of the time with calretinin. So there's pitfalls for all of these markers, so you want to keep those in mind. So, like CK5-6 can stain squamous carcinoma, WT1 stains ovarian carcinomas, and things like that. So you want to keep all those things in your mind when you're formulating your differential. So this one, I just brought a few stains. I won't show all of them, but so this is the calretinin for this case, which you can see is nicely positive here. And this one stained well with all the markers, so it was positive for WT1, it was positive for CK5-6, positive for D240, negative for your glycoprotein markers and TTF1. So this would be an example of an epithelioid mesothelioma.
Okay.
And they can have a lot of growth patterns. The one we showed was very classic with tubulopapillary morphology, but keep in mind they can really look like anything. So they can have the reticular growth pattern, they can have very solid growth pattern, they can even have signet ring morphology, and we'll show some examples as we go along of different ways they can look. Okay.
Sorry, I have a question
Uh-huh.
about the previous one.
Yeah.
Would you call this well-differentiated papillary mesothelioma?
No, well-differentiated papillary mesothelioma is a completely different entity. So that's more common in the peritoneum. They have rarely been reported in the pleura, but those are typically small. You have exophytic papillary cores that are typically lined by a single layer of mesothelial cells, and they're not invasive, or maybe they'll have just what they call little seedling foci, but you don't have diffuse pleural thickening or diffuse disease throughout the abdomen typically with that. That's a completely different entity. But that does bring up an issue about grading with mesothelioma. They all typically behave very aggressively in spite of the fact that they don't look cytologically that bad most of the time. The average survival is only about 18 months from the time of diagnosis, although there's been some improvement in recent years, but you don't call something like well or moderate or whatever. Certainly that's an area of focus for prognostic implications. Mitotic rate, presence of necrosis, and things like that have been correlated with a worse outcome, but they all do pretty badly.
So even that they have a papillary structure?
No, and you want to be careful about that, particularly when you have a peritoneal biopsy that's superficial, because you may just get the exophytic bit of the papillary. So that's when you really want to correlate with your radiology as well. If you've got someone with, diffuse caking of the omentum and tumor all over the place, and you just have a few little papillary fronds, you don't want to call that well-differentiated papillary mesothelioma. Okay, so here we've got another 65-year-old guy with diffuse pleural thickening. So this one's oriented nicely. You've got the chest wall fat on this side, and then over here, what do we have?
It's a very diffuse proliferation of the cells, which at low power look like having a very dense eosinophil cytoplasm.
Right.
And there is a lymphocytic cuffing in the periphery, which is separating the cellular proliferation from the surface.
Right. Okay. So what we have here, we have again a pleura that's way too thick. We have a proliferation of epithelioid cells that extends from the surface over here all the way to the chest wall side. And this lymphocytic reaction at the infiltrating border is not that uncommon with these tumors. So you tend to see that quite a bit if you look for it. But the important thing is that this is invading. So it's going from one side of the pleura to the other. So you have an invasive epithelioid process. This one is cytologically much uglier than the other ones. You have bigger cells. They're a bit more pleomorphic. You can pick out some mitoses here and there that we didn't have in the other one. But what's your differential with this?
I would still think of a mesothelioma first. And it is a diffuse process. Epithelioid mesothelioma.
Okay.
And also, I would like to know more about the history of the patient.
So this guy, again, just has diffuse pleural thickening. He doesn't have any tumor anywhere else as far as we know. And he doesn't have an intraparenchymal lung mass. So it's pretty much just confined to that location. So you're right. So your main differential here is going to be mesothelioma versus a carcinoma. Now this one has a much more solid pattern of growth. So this is the type of case that it's really important to get a keratin on, because you got solid growth. We don't have obvious glands or papillary structures. So you want to make sure that this is staining with keratin, because there's plenty of other tumors that can mimic this morphology that can go to the pleura that aren't either of those. So things like melanoma, some of the epithelioid sarcomas can mimic the distribution of mesothelioma. So a keratin can help you know that you're entertaining the right differential, and that's really critical for this type of tumor. So this one was positive for keratin, and it should be really strong. If you only start seeing like a few wimpy cells that are keratin positive, you really want to stop and think, could this be something else? So again, this one I'm showing mainly just to show a range of features that mesothelioma can show. So this one again was positive for calretinin, WT1, CK56, and D240, and was negative for the glycoprotein markers and TTF1. So this would be again an example of an epithelioid mesothelioma. This one showing a more solid type of growth pattern. Okay. Okay, so the third case, so some of these will do very quickly. Okay, so this one's kind of a two-parter. Okay, so let's look at this area here first. What do we have here? So we've got, again, this is a pleural biopsy. 65-year-old guy with diffuse pleural thickening. We've got the chest wall fat on one side, and then we've got this dense pink hyalinized stuff with kind of a basket weave morphology, not very cellular. So what do we think of this? So I want you to get this burned in your mind, so when we look at some cases down the road, you can tell the difference, and we'll do a compare and contrast.
That is basically we do not see any cellular area rather than the fibrosis.
Okay, but what about the pattern of the fibrosis?
It's like very bland, more collagenized.
Okay, what direction is it growing in?
Parallel.
Parallel, right. So we have very linear deposition of the fibrosis, and that's a very important feature of benign fibrosis of the pleura. This is an example of a pleural plaque. So it's very hyalinized and has this basket weave pattern. But anytime you have pleural fibrosis, the fibrosis gets laid down and entraps mesothelial cells, it'll maintain a linear orientation, which you can appreciate with a well-oriented specimen like this. So we have pleural plaque. Now when you start to lose this linear orientation and it becomes more storiform or it becomes more cellular, then you want to start worrying about sarcomatoid mesothelioma. But this is all very linear and uniform, and sometimes you can have mesothelial cells entrapped in here. If you get a keratin on this, it would be a little more shocking than you might expect, but even the mesothelial cells will maintain a linear orientation. So they should be parallel to the direction of the pleura. And another soft feature for benign pleural fibrosis is when there's retained capillaries, they tend to be perpendicular to the orientation of the pleura. So you've got linear deposition of the fibrosis, linear entrapment of mesothelial cells, and then if they're present, perpendicular orientation of the capillaries. So that's this is benign pleural plaque. So we'll compare this to a case down the road in a minute.
So yeah, so do you also start thinking of SFT when you see fibrosis?
Yes,
like
so
this?
SFT, particularly if you don't have a good clinical history, and I apologize to any clinicians in the audience, sometimes clinicians can be very poor historians, which is another reason you really want to check the radiology and the distribution. So solitary fibrous tumor is going to be a localized mass. Very rarely they can be multiple, but 99.9% of the time it's going to be one circumscribed tumor, and they tend to be pretty large, and they can have a densely collagenous background, but they don't have this linearity. They have what's called a patternless pattern, which is more of an intersecting fibrous or proliferation of spindle cells. Okay, but what I want to show you, so we've got that, so we'll keep this in mind for comparison down the road, but the main thing I wanted to show you about this case are these areas here. So what do we think about this stuff?
We have these glandular areas with mucin, there are extracellular mucin at some places.
Okay, so you think that's mucin?
Looks like.
Looks like mucin, I agree. I agree. Okay, so
And we have, smaller glands too.
okay, so here we get to our first pitfall.
Mhm.
All right, so back in olden times, the differential between mesothelioma and adenocarcinoma was based on the presence or absence of hyaluronic acid production. So adenocarcinomas would produce mucin. Mesotheliomas produce a lot of hyaluronic acid, which would disappear with hyaluronidase digestion. And that was the only way you could tell them apart. Thankfully, we've moved well past that. But this kind of case often just gets sent in as adenocarcinoma without somebody having done any stains, because this does indeed look like mucin. But what this is actually a mesothelioma that's producing a lot of hyaluronic acid matrix. So this is not mucin. So the point of this case is that you always need to do your stains when you have a pleural biopsy, particularly with the distribution of multiple pleural nodules or diffuse pleural thickening, because this is actually hyaluronic acid production. And if we look at our calretinin stain for this one, you can see that it's brightly positive. So, and then this one's stained for all of the other mesothelioma markers as well. And this is that quote unquote mucinous looking area. So this is a mesothelioma. So you don't want to skip doing your stains, even if something has a lot of what appears to be mucin, or even, like I said, if it has a signet ring pattern, sometimes mesotheliomas can look like that. So you really want to make sure you don't skip your stains when you have a pleural biopsy.
So the small glands, at the beginning I thought mucin was adeno too.
Yeah.
But their small glands very, very bland, small, like plastering.
Right.
So are those common in mesothelioma?
Right. So very bland cells. I think, the main thing, even though mesothelioma can look a bunch of different ways, the classic morphology of it is that cells tend to look really bland. So you tend to have these cuboidal cells that have this very innocuous, if you will, cytologic appearance, because these just really don't look that cytologically atypical, but that's one of the deceptive things about mesothelioma. So the important thing here is that it is invasive. This is mesothelial and our pitfall of the hyaluronic acid production.
So Dr. Beasley, so we do not at least think of mesothelial proliferation in a case like this, right?
Well, this is not benign because it's invasive. So you've got infiltrating glands going from one side of the pleura to the other. So, and they're too close together. They're infiltrating in different ways. So this is an invasive mesothelial process.
For those small glands, would you think about adenotoid tumor?
You can have adenomatoid tumors of the pleura. They're pretty rare. If you had just those and just a small individual nodule, that would be a consideration. But this person, again, got to go back to the clinical. So you've got diffuse pleural disease. Here you have areas which don't look like adenomatoid tumor. But on a small biopsy with a poor history, that would be a difficult thing to sort out. Okay, so now we've got case 4, same history. 65-year-old guy with diffuse pleural thickening. Okay, looks a lot like the other one.
Yeah.
All right.
And the cells in the squamous is something not here, but some areas.
Okay.
But here is like probably nucleoli.
Okay, so we've got an infiltrating epithelioid tumor, kind of ugly cytology, big nucleoli, a few mitoses around. So what are we thinking?
Mesothelioma.
Okay, so what's the first stain you want to get? You've got something with pretty solid growth. We don't have a lot of anything that looks really glandular per se. You mentioned that it looks maybe sort of squamoid, but we don't have like pearls or anything like that. So we basically got a very poorly differentiated tumor with more or less solid growth. Okay, what do you want to get before your calretin? Remember I told you this is not the place to be cheap. Keratin. Okay, you want to get a keratin. Your keratin here is negative. Okay. Now what are you thinking?
So still we can do a calretin.
Okay, that's negative.
We can do
Melanoma
a, yeah.
Okay, melanoma markers are a
definitely.
good idea.
Yeah.
Okay, those are negative.
What about WT1?
WT1 is negative. Okay.
This be like a
The vascular marker.
Yes, vascular markers. Very good. Okay, so
Epithelioid Sarcoma.
there's our star for the day. Okay, so epithelioid angiosarcoma often is the thing that gets diagnosed after your first round of immunostains doesn't work out and you're thinking, oh, it's not mesothelioma after all. But that's why your keratin's important. So some of these epithelioid angiosarcs will show some keratin staining, but you really shouldn't have the diffuse strong staining that's typical of a carcinoma or a mesothelioma. It's going to be much less. Similarly, your mesothelioma markers aren't going to be positive, so you're going to, even if you skip the keratin, you're going to end up with this messed up panel that doesn't make any sense or it's not staining. So one of the first things you want to think about when you've got an epithelioid tumor that's either keratin negative or only weakly positive is a vascular malignancy of the pleura. So not to say that they're common, but that's sort of the next most common thing that you want to think about. And if you look around, we do see a lot of blood here. And at first glance, we're of course just thinking that's procedural from the biopsy. But if you look at the tumor more closely, you can see that it does appear that at least some of the tumor cells are trying to make vascular structures. And I still can't seem to get the pointer working, but here we have one that's at least trying to make a vascular structure. And if you look around, you can find some more of those that you just, probably thought was hemorrhage to start with. Working? I can't see it. Can you see it?
How about the next one? It was white also, white spot.
We want green. Does green work better than red? Are we bright? Yay. Okay. We'll get it done by the end. Okay, yes. So here we've got making a vascular structure. So if you start looking around, you can kind of pick that out. So this is going to be positive for your vascular markers. So things like CD31, FLI1 ERG, things like that. So these just keep in mind as a pitfall for epithelioid tumor of the pleura. Okay, so along the same lines, we've got this.
Okay.
Okay.
A lot of fibrosis.
A lot of fibrosis. We've got maybe some plaques starting to form here. It's got a lot of pleuritis on the surface. We've got some fibrin. Here's those perpendicular vessels I was talking about with benign fibrosis. But
We have
down
something
here, we've got something else.
There's some signet appearance. Small like signet ring areas. The cells are in close proximity. Looks bland, but we should this can be a vascular tumor like a Hemangian mesothelioma, epithelioid Hemangian mesothelioma, something like that.
Okay. All right. See, now you're thinking because we showed you the case before. Okay. So that's good. Right. So you have an infiltrating tumor. Usually these will have kind of a myxoid or myxochondroid background. We're not seeing that quite as well here. But the cells have this sort of very vacuolated, almost signet ring type look to them. If you look around, usually you can find maybe some red cells in the lumen of these. We won't waste time looking for that, but you can sometimes see those in the middle of these. But so you've got another epithelioid tumor of the pleura. So again, this is where you don't want to be cheap. So you want to get your keratin. This is again going to be negative or perhaps weakly positive. You shouldn't see strong diffuse staining. And then your vascular markers are going to be positive. So these, when they occur as primary pleural tumors, still tend to behave very badly. So at one point there was debate about whether they really needed to be separated from epithelioid angiosarc in this location. However, as we now know, epithelioid hemangioendothelioma has a characteristic molecular translocation and things like that. So I think it warrants keeping them separate since they do have these unique features, even though the behavior in this location anyway is not that different from epithelioid angiosarcoma. Okay. Okay, our final one on this theme. A lot of necrosis. Okay, and I think this one's a bit of a zebra in this location. I'll give you that. Okay, and this would be more typical to present as like a big mass kind of encasing the hemithorax.
There's a lot of myxoid background, some vascularity, and cells are in small clusters. Still, there are some signet ring-like cells, but they are coming very in small collections, groups and nests. And yeah, the cells have a lot of vacuolated cytoplasm that we can appreciate. And there's some pigment, it seems.
Okay. Is it pigment or just
maybe just hemosiderin, yeah. And yeah, these cells are coming singly as well. There are some single cells and vacuolated cytoplasm. And
what about like these kind of guys? What about the vascularity?
Vascularity is quite.
Would we describe it in any particular way?
Chicken wire.
Yeah, it's not the best example, but it's kind of chicken wiry. You've got these vessels around. And then, as you said, you've got some single cells, some of them with kind of a signet ring morphology. Then you've got some guys with like multiple vacuoles.
Like lipoblasts?
Right, exactly. So you've got lipoblasts. Okay.
So we can maybe myxoid liposarc can be thought of.
Right, so this is a myxoid liposarcoma. Now, these, as you might imagine, are extremely rare as a primary pleural tumor. But the point of showing you this is it does have overlapping features with epithelioid hemangioendothelioma. Like if you just had a smaller biopsy and only had this, that might be a consideration. And similarly, you can sometimes have clear cell or signet ring cell change in a mesothelioma. So if you had a smaller biopsy where you couldn't really appreciate all the features or maybe couldn't find a good lipoblast, you might be thinking about a mesocarcinoma diagnosis in your differential. So like if you had, for example, just this area that had some cells with some clear cytoplasm, you might still be thinking about mesothelioma or adenocarcinoma, thinking this was mucin in the background if you didn't have all the features. But this is a myxoid liposarc. When you get liposarc as a pleural primary, the myxoid subtype is the most common, if you will. So this is just a reminder that really anything can happen in the pleura, and you want to think about your sarcomas and your soft tissue tumors in particular. So there's really only one really good study that's a series of liposarcs of the pleura, so they're pretty uncommon.
The vascular structure is a common.
Myxoid liposarc is a pleura.
Yeah, so myxoid liposarc in general is going to have that chicken wire vascular pattern, so that's also a clue here. Okay, so we're going to shift gears a little bit now. All right. So again, 65-year-old guy, diffuse pleural thickening.
And again, fibrosis, but this time it is more cellular.
Right.
And it's not all parallel.
Right. Okay, very good. Not all parallel. Okay, so we do have an area here that's still more plaque-like, so very linear, not very cellular. But then even here you can see it's starting to get a bit more cellular. So this would be an area that would be bothersome on biopsy, particularly because you've got some cells infiltrating the fat over here as well. But I think if you just had this, it would be tricky. But here it's getting much more cellular, more pleomorphic here. And then much more haphazard growth pattern as you kind of look around as well. And then importantly, this is a good area here, you have areas of what's called bland necrosis or coagulative necrosis, and here it's actually infiltrating into the lung parenchyma.
So was it a localized mass or diffuse?
Diffuse. And here it's infiltrating the lung also. And here. And here we have some areas that are much lower cellularity, but they're still losing their linearity. You've got a bit more of a storiform type growth pattern and then this dense collagenous background.
So here we can take solitary fibrous tumor.
Okay, if you just had a little core biopsy, you know, think about that. But this guy's got diffuse disease. Okay. So what do we think? So we've looked at a bunch of epithelioid tumors, and now we've got something that's spindle.
Can I have a spindle cell mesothelioma?
You can. All right, so you've got mesothelioma in 3 flavors, basically. So you've got epithelioid, you've got sarcomatoid, and then you've got tumors that are a mix of the two, which are biphasic. So here we have spindle cells. So what's your differential here? Okay, so sarcomatoid mesothelioma is obviously something you want to think about. And again, this is where your radiographic distribution and knowledge about the patient is really critical. So you want to make sure that the patient has the appropriate disease distribution for mesothelioma. So you want to see multiple pleural nodules or diffuse pleural thickening. That's because when you have this type of morphology, your differential is primarily with sarcomatoid carcinoma or other sarcomas. So even though sarcomas can mimic the distribution of mesothelioma, particularly the epithelioid vascular tumors, most spindle cell sarcomas are going to present as a mass, or they're going to be metastatic from someplace else, with an exception we'll show in a minute. But sarcomatoid carcinoma could be from the kidney, so you want to make sure the person doesn't have a renal mass. But sarcomatoid carcinoma of the lung only rarely presents with a mass so peripheral that it will produce only pleural disease. So what you're going to see classically with the sarcomatoid lung carcinoma is a big intraparenchymal mass. So the radiology is going to be really critical for this, because sometimes your stains don't work very well. But your most important stain that you're going to get for this is what?
Keratin.
Keratin, yes, your absolute most important stain here. So sarcomatoid mesothelioma should be keratin positive, and they're usually reasonably so. You can get some that are kind of wimpy, but for the most part, it should have pretty decent keratin staining. So that's the most important thing. So essentially, if you have something that's keratin positive and the disease distribution is appropriate and it all fits together, then that's really strong enough to go ahead and call something sarcomatoid mesothelioma, provided he's got the right disease distribution. Now, your other stains that you typically get for your mesothelioma differential diagnosis for the epithelioid type don't apply here so much. So you get cases sent in all the time that have like CEA and B72.3 and things like that done on them, but that's not really applicable here. Your mesothelioma markers can still be used. A lot of the sarcomatoid ones will be negative for the mesothelioma markers, though. If you're lucky, it may stain for calretinin or D240. Those are the two that most commonly will stain. Mesotheliomas, WT1, not so much and almost never for CK5-6. But those can be helpful when they're positive. But again, you want to be careful about that. There's some pitfalls with those that I'll show in a second. But that's basically it. So if you got something that's keratin negative, you want to be really careful. Consider other sarcomas. Consult your favorite soft tissue pathologist. Pitfalls, sarcomatoid meso can be positive for actin on occasion, so that can be confusing with metastatic leiomyosarcoma. Usually the actin staining in mesothelioma is very focal and wimpy compared to leiomyosarc though, but you want to be aware of that pitfall. And so this one you would call sarcomatoid. This one has some areas like this, which I pointed out, very low cellularity in this fibrotic background. So it's starting to get what's called a desmoplastic appearance here. Mm-hmm. And this, I think, is one of the hardest diagnoses really in the whole of pulmonary pathology because it can be so subtle. So what you want to see with this is storiform morphology. You want to see it invading things like we're seeing it invading the lung here. If you see bland necrosis, that's helpful. And then one of the other criteria is distant metastases. So obviously if you got that, you know it's malignant. And then if it has other, frankly, sarcomatoid areas mixed in with it, then you know that this is a malignant area here. But honestly, if you've got this area, you're not quite as concerned about what's going on over there, but this can be very tricky. And this is the kind of thing you might confuse with solitary fibrous tumor if you don't know the history. So if you just get something, you know, pleural biopsy, you don't know if it's a single mass or not, you may confuse it with solitary fibrous tumor, depending on what the core biopsy looks like. Mesotheliomas are going to be negative for CD34, and they're generally negative for BCL2, and they should be negative for STAT6, which are two things that should be positive in solitary fibrous tumor. And then, of course, mesothelioma is going to be positive for keratin, which is going to be negative in solitary fibrous tumor. Okay, same story, a little bit younger guy, and I apologize that this slide is not the best. But so I'm showing this to point out an important pitfall. So that tells you it's not mesothelioma right away.
It's cellular still, but cells look bland. And
they all look pretty similar. Mm-hmm. Now, I know this is not the biggest piece, but if we had a bit bigger piece, you'd see areas that were dense like this, and you've got, you know, kind of a, not quite a herringbone, but, you know, more uniform proliferation of spindle cells that look pretty similar. A little bit of fibrosis in the background. And if we had a bigger piece, you would see areas that maybe were a little less cellular, maybe have a bit more prominent vascularity than we're appreciating on this small piece. But this is sort of a good area here. So we have spindle cells all looking pretty much like their neighbor. Mm-hmm. So what are we thinking? Now this tumor can present as a primary pleural lesion, either as a localized mass or as multiple nodules or diffuse pleural thickening. Or it could be metastatic from someplace else.
Synovial Sarcoma?
Very good. Okay, so this is another one where you want to get your keratin. So when you get a keratin on these, it's either going to be, depending on your sample, it's going to be hard to demonstrate keratin staining. Maybe you're just going to get a few cells, depending on what it looks like, but it's not going to have diffuse keratin staining.
So you're talking about synovial sarcoma, right?
Right. So this is a synovial sarcoma. Now your big pitfall with these is synovial sarcomas, a significant percentage of them are going to be positive for calretinin. So you don't want to get something with a little bit of keratin. and some calretinin staining and call it a mesothelioma just based on that. You want to be really careful about basing your diagnosis just on one marker. You want to know the pitfalls, and you want to know other things that can occur in the location that can mimic this. So in the pleura, any of the synovial sarcoma subtypes can occur, but the majority of them are monophasic. In my experience, they all look pretty similar to this one. They tend to occur in a little younger population than your typical mesothelioma person, so that should be a clue as well, although they can occur in any age. So helpful stains here are going to be what? TLE1 is going to be good. And even though BCL2 and CD99 are by far from specific for anything, they will be negative in mesothelioma and positive in synovial sarcoma. So when you're down to that very narrow differential, those can be supportive of that. And then, of course, if you're really stuck, you can get your molecular translocation for X18. So you want to keep that in mind, and particularly the pitfall that they can be positive for calretinin.
What's the CD99 stain? This like focal positive, diffuse positive,
Whatever it was. The CD99, we joke it stains 99 different things. So, so it's by far from specific, but it's typically negative in mesothelioma. So, it will throw, if you're looking for things to support synovial sarc, if you got it down to those two things, then that'll help you with that.
What is the other stain you mentioned? CD99 and
BCL2 obviously positive now. So again, not a stain that's restricted to that by any means, but it'll be positive in synovial sarc and negative in mesothelioma. Okay, so here we've got a lady with multiple pleural nodules. Spindle cells infiltrating fat. Yeah.
There's some kind of myxoid background.
there's some collagen in there.
Yeah.
Okay, so what do we want to do? Your case, you're sitting at your desk. What can it be?
Some neural.
What's the first stain you want to do? Cytokeratin. Your keratin is negative. Okay, so got a negative
So is it a single mass, you said, or
multiple nodules.
okay, multiple? It can still be SFT.
Okay, so CD34 is negative.
Stat 6 negative.
Stat 6 is negative.
We can do a neural marker.
Neural marker.
S100.
Okay, S100 is super strongly positive.
So it can be an MPNST.
Okay, what else could it be?
What about HMB45?
Okay, HMB45 was not positive.
Melon
A showed some patchy staining.
So
So what do we do?
actin. What about actin?
Okay, actin was negative.
So it can still be a melanoma, but you said HMB45 is negative.
I'm sorry, what?
You said HMB45 is negative.
Right, but this is a spindle cell one. So remember, the spindle cell ones don't always stain for HMB45 the same as the
S100
epithelial
is
ones.
positive.
S100 is off the charts positive on this.
Then melanoma still. Still it can be melanoma.
Didn't get that. We can pretend it's positive if you want. So, but this was a burn. We just actually got this case a couple of weeks ago, and this person actually had a history of melanoma that the clinician neglected to mention. So they thought this was going to be mesothelioma. So it was one of those, we get the stains, the keratin's negative, and we're like, oh, for heaven's sakes, what's going on here? And, spindle melanoma going to the pleura, we don't see that very often. More often it's going to be, your conventional, more epithelioid type melanoma when it's in the pleura. So this one took a few rounds of immunos to sort out, plus the clinician being like, oh, by the way. So, but she did have a history of melanoma. So this is metastatic spindle cell melanoma to the pleura. But I wanted to show melanoma in particular because melanomas, particularly the more conventional epithelioid type, can be positive for WT1. So again, that's an issue. If you skip the keratin and then you've got a positive WT1, you can make a mistake and call something mesothelioma when it's not. So again, you don't want to rely on one marker and you don't want to skip the keratin. Okay, this was an interesting guy. So this was a guy from Bangladesh that had a quote unquote pleural tumor resected that we knew nothing whatsoever about that recurred.
Oh, this is a recurrence.
Yeah, this is a recurrence.
And single, multiple.
This was kind of a big conglomerate thing, and it was invading the chest wall.
It's growing fast.
It was not, but yeah, so this occurred over several years' time.
It's again spindly.
Spindly, bland,
Hypocellular.
hypocellular.
This is like a carrot, the shred carrot.
It's
What shredded carrot? Shredded carrot.
I don't know. Shredded carrots. It's not a granular cell tumor.
No, I mean the neurofibroma.
Oh.
This is not like, this doesn't have a neural look to me, I think.
Well, certainly that'd be in the
Oh.
differential because you've got kind of these
Yeah, wavy.
but the neural markers were
Negative.
were negative.
I will do beta catenin.
Ah, yes,
Positive?
it's positive.
Ah.
Beta catenin positive.
Yeah, that's why I'm asking whether it's a fast growth.
So it's fibromatosis.
It is, yes. This is a desmoid tumor of the pleura. So this can again rarely occur in this location. When this was initially resected, we were told it was called solitary fibrous tumor. You can kind of see why somebody be thinking that. I don't know if they stained it or didn't stain it or anything like that, but you can imagine that, somebody, common things being common, they get a spindle, something that's a mass in the pleura, and are going to call it solitary fibrous tumor. But you can see the vessels are different. You don't have those quote unquote hemangiopericytomatous blood vessels that you would expect with solitary fibrous tumor. And at the background collagen, you've got fibrous tissue, but you don't have that ropey wire-like collagen. And solitary fibrous tumors tend to be pretty well circumscribed, and even though this is fragmented, you can kind of appreciate that it's kind of transitions from areas of cellularity and it's kind of infiltrating the soft
There's some
tissue.
inflammatory sprinkling, like there are some inflammatory cells here and there. Some lymphocytes.
Yeah. Good. You guys are stars. All right. Yes. A desmoid tumor of the pleura. Keratin negative. Okay. Oh, we're going to get through these, it looks like. Okay. So here's one that's just a mass. Mass of the pleura.
So again, solitary, diffuse, what is it?
Solitary.
A single tumor?
Single
Mass.
tumor.
Okay.
Classic. Okay.
Classic.
This stuff here.
This is SFT.
Yes, this is an SFT. Okay. So we have spindle cells, variable cellularity, this ropey or wire-like collagen, very characteristic cells kind of in the so-called patternless pattern. And then if we back up a little bit, talk about a couple of other things, but certainly prominent vessels, maybe not the best staghorn vessels on earth, but a little bit of that going on. So these are going to be, what's your immuno workup for these? Stat6, right? And
BCL2, CD99,
all positive.
CD34.
CD34 positive. Keratin negative. Okay, now, tricking you. Okay, so we've got this area here, which is necrotic.
Yeah.
And this was a huge tumor. And I should have dotted some areas, but this does have mitotic activity. And how many mitoses are we looking for? Here's one.
5 per 10.
4 per 10. We'll give you credit though. Okay, so increased mitotic rate. So yeah, so basically 4 mitoses per 10 high power fields, necrosis, too much cellularity. So this is a malignant variant of solitary fibrous tumor. And you can see how this can overlap greatly with synovial sarc or potentially sarcomatoid mesothelioma, particularly if you had one of these more cellular areas on small biopsy. So again, your keratin stain is critical, and then you want to tailor your immunopanel accordingly. Then this area here is more classic. So if you start seeing this ropey collagen, sometimes you can see that in synovial sarc as well, but it's usually not as prominent, and your immuno should readily sort those two out. Very classic. Okay, last one.
Single, multiple.
Multiple.
This is a lot of, oh, this is Rosé Dorfman. Looks like.
Rosé Dorfman, oh my.
I don't know.
I'm not sure I could diagnose that myself.
I don't know.
No, we'll pretend. Okay.
No, it's Mesothelioma.
Right, so you've got lymphoid cells, and small, nice,
A lot of
happy-looking
histiocytes.
lymphoid cells, and then you've got these guys here. Okay, so let's talk about these guys here.
Yeah.
What do we think about them?
Histiocytes. Looks like.
Okay, so your clinician is once again a poor historian.
It can be some hematolymphoid, some hematologic thing too.
Okay, so if you don't have a story on this, you can go down all sorts of different paths.
And
Can be some-
histiocytic cells too, right? Like lymphoid histiocyte.
Right?
So,
So this is cytosis? No,
no, there
this
is
is not
like,
the, how to say, LCH, because of the eosinophils.
so we are not seeing eosinophils, right?
Right.
No.
There are no eosinophils. So it can be,
Yeah, I thought I read a slide. This one doesn't have it. So this was also very fibrotic. So I grabbed a slide that was not showing that. But so this did have some big fibrous bands in it. Okay, so you've got multiple nodules of the pleura. Okay, so you've got some sort of bland looking cells with small nucleoli here with lymphocytes in the background. And these are sort of round, somewhat cohesive, maybe not. So your differential's pretty broad here, given that our clinician neglected to tell us a key important bit of information. Okay.
So is it a myeloid sarcoma or something?
No, and I wouldn't go trick you guys that badly, but always a good thought, because anytime you're struggling with something and something isn't adding up, myeloid sarcoma is always a good thing to think of. Okay, but backing up our decision tree, we've got multiple nodules in the pleura. You've got these kind of not too cytologically ugly epithelioid cells with lymphocytes in the background.
Two components.
Ah, 2 components. Yeah.
Avoid and lymphoid.
Right. Okay, very good. All right, so this is a drop metastasis of thymoma to the pleura. Okay, so once again, clinician not telling us a key piece of information that the patient had a thymoma resected last year.
Wow.
Okay, so now if you didn't know this, okay, you can have certainly some sort of lymphoma might be in your differential here. You know, having a component of larger cells with some smaller cells in the background. You can have a so-called lymphohistiocytoid variant of mesothelioma, so you might consider that in your differential. That's going to stain with keratin in your mesothelioma markers. But again, pleural biopsy, you want to get a keratin. So all these cells are going to be keratin positive. So you've got keratin positive cells, meso markers negative, lymphocytes in the background. And sometimes they will retain the big fibrous bands and the lobular architecture of thymoma as well. But that's what this is. So this is drop metastases of thymoma to the pleura.
So this one will be P63 positive?
Usually they are. That's more common in thymic carcinomas than thymomas. Sometimes these will pick up some CD5 staining as well. But essentially you'll have keratin positive cells with the CD3 positive lymphocytes in the background, and then you need to pick up the phone or, and talk to your clinician. And they'll be like, oh yeah, that's what we thought. Okay, so you guys did great.
Thank you.
Okay.
Thank you.
Any questions about any of the cases or other pleural issues? Or
Yeah, like regarding the differentiation between mesothelioma and mesothelial hyperplasia, or reactive mesothelial hyperplasia.
Right. So, yeah, we didn't do benign versus malignant, but essentially, architecturally, the biggest thing that discriminates mesothelioma from reactive mesothelial hyperplasia is the presence of invasion. So you want to look for that in particular, and that's why it's hard to make a diagnosis of mesothelioma on cytology, because reactive proliferations can look all sorts of crazy ways. Particularly things like eosinophilic pleuritis, you can get a lot of reactive mesothelial proliferation with that. So you want to see it invading into the underlying stroma, and you want to be cognizant of pitfalls like entrapment. So remember when I was talking about fibrous pleuritis, the mesothelial cells get entrapped in a linear fashion. So you want to see cells going in different ways, irregular tubules or tubules infiltrating particularly deep in the pleura. Obviously, we're all looking for a magic immunostain to tell benign from malignant, and many have come and gone. I think if you're going to read one paper about mesothelioma, you want to read the guidelines paper that with Aliyah Hussein as the first author, because that goes through benign and malignant and all the pitfalls that we talked about today with the staining and the differential and that kind of thing. We're in the process of updating that now, so there should be a new version at the end of the year that's really going to update more of the molecular stuff and some staining stuff. So, go ahead and read the one that's out now. It's very good. And so things you can do, P16 deletion by FISH, I think has evolved as one of the better things to discriminate benign mesothelial cells from malignant. If it's not there, it doesn't help you, but if it is present, it will, and it's present in most of the sarcomatoid mesotheliomas, variable percentage of the epithelioid ones, but you can't use the immunostain. You have to do it by FISH. Another thing that's come along is BAP1 deletion, which is a mutation that you can see in mesotheliomas. So again, it's not present in all of them, but if you have loss of BAP1 staining, that supports malignancy over a benign proliferation. So none of these things are like totally, I suppose, depending on your comfort level, a lot of people, if they have, say a cytology or a small biopsy and you've got P16 deletion and BAP1, you'd maybe say favor mesothelioma. Some people are a little braver and maybe would go ahead and call it. But I think we're evolving to a point where we do have some markers that seem to be holding up over time, as opposed to ones that have sort of come and gone over the years. Other things people have tried, like Desmond, that I have not found that very helpful in the literature on that's very variable. GLUT1 is another thing that you can use. It's kind of a messy stain though, but we're probably going to evolve to where we have a panel like we do for meso versus adeno, and then maybe if we have all of these things together in a difficult biopsy where you're having trouble seeing definitive invasion, or maybe there's a question, that those things will be helpful. But so far, P16 deletion and BAP1 loss, I think, are the best things that are kind of coming up.
So that one is immuno?
Yeah, I actually brought one to show you guys. So this was the, we've only had this marker a few months, but this was the first case that I showed you. So it should be a nuclear stain. So these are, and it stains things besides mesothelial cells. But if you look at the mesothelioma itself,
it's negative, right?
right. So you can see you've lost the nuclear staining in the tumor.
So this is
So-
BAP1.
Yeah, so you've got BAP1 loss in this particular tumor. And this is something that we're currently looking at to shore up when something is sarcomatoid and when it's not. Again, you don't see BAP1 loss in every mesothelioma, but sometimes it's hard to tell like exuberant fibrous proliferation in the background compared to a true sarcomatoid component of a mesothelioma. So if you've got positive keratin staining and loss of BAP1, then that would support that it's a sarcomatoid part of the mesothelioma rather than just entrapped mesothelial cells in fibrous tissue around the background. So things to look forward to.
Thank you, Dr. Beasley.
Thanks, guys. You guys did well.
Thank you, everyone who has joined online. And our next talk will be on liver pathology by Dr. Neil Thies, which will be on July 19th. So hope to see you. Thank you.
Yeah, this is just the regular meso. The regular meso. Yeah, so your question about well-differentiated papillary. So this one does have papillary.